It's a great pleasure and privilege to introduce Dr. Alicia Lieberman for the last session of this conference. I just had the most incredible experience a few minutes ago realizing that Alicia's sister, Shoshi, is a social worker, a colleague and a friend whom I know for years and years, and we never came to this connection before, so it's really a small world, and definitely Israel and the Jewish people are small. Dr. Lieberman is the Irvin B. Harris Endowed Chair of Infant Mental Health in the University of California, San Francisco, Department of Psychiatry, where she's also a professor and vice chair of academic affairs. She's director of the Child Trauma Research Program at San Francisco General Hospital and clinical consultant with the San Francisco Human Services Agency. She is the co-creator of Child Parent Psychotherapy, CPP, an evidence-based intervention for infants and young children who have experienced trauma in the family. The Haruv Institute was fortunate enough in that she, along with the late Patricia Van Horn, agreed to teach over 100 professional psychologists and social workers CPP in Israel, where it had made significant change in the way clinicians see and treat problems of early childhood in Israel. So the floor is yours. We're looking forward to your talk.
Thank you very much. It's a great privilege to be here. I want you to know that my family, my grandparents were born in Sfat and Tiberias and emigrated to Paraguay, and then my parents came back in 1967 with my sisters and me, and I did my BA at the Hebrew University, part of my MA at the Hebrew University, and come back every year, and this is my home, my spiritual home, and I'm just so grateful to Asher Ben Aryeh for having invited me to bring CPP here, and to Paula for having been my partner with Patricia in creating a group of therapists and trainers in CPP, and it's a great privilege to be here. And it started with a conversation with Freda Fagelson and Paula about what did babies need and what could we provide to them. So thank you very much for having me here. I was asked to talk about trauma in early childhood in terms of the long-term dangers of not identifying early childhood and trauma and the long-term consequences. And I was remembering that in the 1960s, child abuse was just discovered as a phenomenon, and it was considered as something that was likely to be very rare. Well, the statistics certainly show that it is far from rare, and we'll go over some of the statistics together. But I was thinking as I was preparing this talk that some of the emotional, psychological, sociological distance that was manifest in that early idea that child abuse is a rare phenomenon continues to persist, and it is manifested in the gap between the prevalence of child abuse on one hand and the continued inadequacy of resources in the systems that should be totally equipped to respond to the tragedy of child abuse. And I believe that young children are particularly affected because we continue to believe that little ones, 1-year-olds, 2-year-olds, 3-year-olds, 4-year-olds, are too small and too cognitively immature to remember what happened to them and to suffer long-term consequences from what happened to them. And so I think that the title of this international conference is particularly important and particularly apropos in calling it child abuse in context, because it is the context of the family that I think both makes child abuse happen and continues promoting the long-term consequences that children experience. I'm just trying to figure out how to, okay. So when we talk about prevalence, I wanted to talk specifically about a group that was in the United States, middle class, primarily white European, employed, and unlike many, many people in the United States, had medical insurance, the Kupat Holim equivalent of medical insurance. It's called Kaiser Permanente. And in that study of almost 18,000 people, 28% reported to their primary providers that they had experienced physical abuse when they were growing up before age 18. 20% of men and women, 24% of women, 16% of men reported that they had experienced sexual abuse. And a smaller but still significant percentage reported that they had experienced emotional abuse. And remember, this is not a poverty population. We tend to associate poverty with child abuse. It's a form of, again, distancing and saying this is not likely to happen to us. And one of the, just as an aside, I want to say in my training of child psychiatrist and child psychologist at the University of California, San Francisco, one of the most difficult things to convey is the importance of asking about trauma exposure to a family that is middle class. It's as if being middle class is automatically considered as a protective factor against child abuse, and yet we know that child abuse exists in all social classes. The additional component, and the reason that this is so important to think of child abuse in context, is that we were, when the investigators, the Kaiser Permanente investigators, Vincent Felitti and Andrew Anda, looked at the household situation in which childhood abuse occurred, they found a very high percentage of substance abuse, separation or divorce, but primarily the child not having access to both parents after separation or divorce. So essentially parental loss, loss of contact with one parent. Mental illness in one of the parents, domestic violence, and a small but still significant percentage of incarcerated family members. So here we have to understand the context in which child abuse existed, and one of the important findings of the study is that only 36% of the respondents, and again, middle class, employed, European American, privileged people, only 36% said that they had none of these adversities that were asked about. And an almost equal amount, 38%, had at least two and sometimes four or more of these adversities. So that tells us how prevalent trauma is, and in other studies, it was found that the likelihood of having one adversity, child abuse, domestic violence apparent with mental illness is associated with an 80% increase in the likelihood of having at least one other adversity. And this is particularly important in the kind of research that we're doing, because until very recently, we tended to specialize in particular areas of adversity: domestic violence, physical abuse, sexual abuse, child neglect, etc. And in fact, when we look at the topography of adversity, we find that there is an overlap that ranges from 40 to 70% between child abuse and domestic violence, and that young women who grow up in homes where there is domestic violence are exponentially at higher risk, something like 10 times more likely to be sexually abused than young women that were not raised in homes with domestic violence. And so once we have a child referred to us or identified in our research as having one kind of exposure, I think it has become our scientific, clinical, and moral responsibility to ask about other kinds of adversities as well. Now, in the A study, in the Kaiser Permanente study that I'm talking about, we were asking, the investigators were asking patients, medical patients, to retroactively remember what happened to them when they were young, when they were growing up. In a study that we're conducting right now with almost 11,000 children as part of the National Child Traumatic Stress Network, and where we're asking about the original adverse childhood experiences, we found that in children that are referred right now, there is a mirror image of the picture that was reported by the clinical patients in Kaiser Permanente. And this is particularly important because when the Kaiser Permanente findings came up, the response of many, many researchers was, these are people who are remembering wrong. When people are depressed, when people are sick, they are likely to remember bad things from their childhood. We have no systematic documentation that this physical abuse, sexual abuse, domestic violence that they are reporting actually happened. And these findings then replicating those findings in the here and now with the referring information from the treating clinician saying this is documented in the clinical chart right now shows that we can really believe the Kaiser Permanente data. And here again, over 40% of the children that were a part of this sample have 4 or more different types of trauma and adversity. So here again, if you have one traumatic experience, then you are much more likely to have at least one other one. And when we look at the rates of maltreatment by age, we find that almost 55% of the children were between 0 and 3 when they had the child abuse or the traumatic event, and a little more than 30% were between ages 4 and 6. And that as we look at the association between age of first abuse or other traumatic experience and presenting problem, there was a strong association, positive association. The younger the child, the more likely to have more intensive symptoms and more frequency of symptoms. So this, I think, takes us to the findings that more children die from abuse in their first year of life than at any other time in the United States, and half of child abuse victims are under age 7, and 85% of abuse fatalities are under age 6, and children birth to 5 are also more exposed to domestic violence. And that in turn takes us to the importance of looking at child abuse in the context of a trauma framework. The prevalence, the early beginnings, and the association of child abuse with other forms of trauma say child abuse needs to be considered as one more component in a trauma framework, where trauma is defined as an event that overwhelms the child's capacity to cope and to prepare and to modulate emotion in response to the traumatic event, where the sense of physical integrity and psychological safety is overwhelmed, and the key features are that it happens unpredictably, that it produces horror, and that it creates a sense of helplessness. Now, again and again, we are asked, do young children remember? And I think that this comes from, again, the sense of distancing from the idea that young children can be hurt that much and that the damage that they experience really persists. I'll give you an example. In the 20 years that we have been exploring early childhood trauma, we are amazed at the way children whose child abuse or domestic violence has been documented in the child welfare charts, in the police charts, etc., but who were pre-verbal when it happened. Once they acquire language, they tell us what happened. And one example that I want to give you is that one of an 8-month-old who was referred with severe head injury as a result of child abuse and was hospitalized for about 2 weeks until he recovered. And then, of course, the child welfare system, in its wisdom, felt that this child needed to have visitation with the offending parent, who happened to be the father. And as part of trying to see whether reunification was possible, and this is one of the many dilemmas that we experience in terms of the hard questions of when is removal of a child indicated, when is reunification of a child advisable. If reunification is not advisable, then what can we do to provide secure, stable, permanent attachment relationships to the child? This 8-month-old, as part of the treatment planning and of the long-term planning, was expected to visit with his father. When the foster mother brought the child to the visit, the child started shaking violently, arching his back away from the father and turning away from the father. And when the foster mother persisted, because she was expected to persist, in giving the 8-month-old to the father, and the father held the baby rather lovingly, the child started screaming inconsolably and only stopped crying when the father gave the baby back to the foster mother and the foster mother left the room. And it took him quite a while to continue to stop. And that night, for the first time in many weeks, he kept waking up, screaming, and he kept throwing up the milk that he was given. This happened when the baby was 10 months, this response to the father. When the baby was 12 months old and visitations again were reintroduced, he would go no, 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 when he was told that he was going to visit his father. And at 18 months, when he was told about visiting his father, he said, no, daddy, no, daddy, no, daddy. And he had tremendous temper tantrums. And at the same time, the judge felt that this child was too little and that it was very possible that it was the separation from the father that was causing this kind of very intense reaction. And that leads us to the question of how difficult it is to read a baby's signals, to interpret a child's behavior, and to make wise decisions about what is going to promote the child's healthy development. But we do have to admit that our own predispositions is to think that if a very frightening event is perpetrated by a caregiving figure and the child then refuses to have contact with that caregiving figure, that we need to take that behavior very, very seriously. And this is another way of saying that, that the body remembers, that children remember. This is a slide that is disseminated by the Centers for Disease Control, and it is part of the presentation that Vincent Felitti and Anda give as part of the Kaiser. This scanning of a brain is the one of a 3-year-old who has been severely abused and neglected. And you will find that it has many more dark areas, which are cavities of the brain that are filled with fluid rather than with brain tissue. And particularly, you see that the corpus callosum is not visible in this particular slide, compared to this one, which is that of a normally developing 3-year-old. My dear friend and colleague, Patricia Van Horn, that you referred to, Anat, used to say to me, I don't like it when you show that slide. And I would ask her, why don't you like it? And she would say, because it is a static view of the brain, and we know that the brain is an organ that is very dynamic. And because hope and momentum towards health are the most important ingredients of trauma treatment, and giving people this slide comparing a traumatized photo of the brain versus a normal photo of the brain will make everybody in the audience who was ever abused or ever traumatized feel I'm damaged forever and lose hope. And so, like everything else in the field of trauma, I think we need to have a point-counterpoint. We have to have the darkness and the light. And we have to be able to acknowledge the very graphic consequences of prolonged and persistent and intense child abuse together with the hope for recovery under the proper circumstances. But for me, the reason that this is such a powerful image is that it says trauma lives in the body, and it is not a figment of imagination. It really has biological consequences, physical consequences. And because function follows structure, sometimes the question of without tissue that is involved in affect regulation, in goal-oriented planning, in logical thinking, what happens to a child in the here and now? We know, for example, that there is a very high percentage of expulsion of 3 and 4-year-olds from childcare in the United States as a result of aggressive behavior. When we start asking, why is this child aggressive? And we find out that they have witnessed domestic violence, they have witnessed community violence, they have been physically abused, then we start thinking their whole body, sense of the body and the brain physiology and the brain structure are being affected by what happened to them. And instead of expelling them, we need to create the conditions in the childcare to contain them, to modulate them, to make them feel safe, and to help the parents change the circumstances in the home in order to help them feel safe. And together with this, the words that go with that picture are that the brains of children who have been abused have larger lateral ventricles and smaller volume. We have dysregulation of stress hormones. We have children that respond much faster to stimuli that are neutral, as if they were threatening and dangerous, than children who have not been abused. And we find that at the level of the chromosome, the parts of the chromosome that are associated with biological aging are accelerated in children that have experienced abuse versus children who have not. So the biological picture of child abuse is getting more and more specifically defined. And the cognitive effects that are associated with this involve, for example, 5-year-old twins exposed to domestic violence who showed an 8-point loss in IQ compared to their twins who were not exposed to domestic violence. 8 points in IQ is higher than the IQ points that are lost from exposure to lead. Children that are exposed to lead have on average 4 IQ points lower in their performance than children who have not been exposed to lead. This is double the amount of lead exposure. And in a range of variables, including memory tasks, we find the same thing. Now, the good news is that because the brain is not static, this is not necessarily what remains. And I just got an email, for example, from one of my postdoc fellows showing that as we look at the IQ findings when children are referred for treatment to child-parent psychotherapy, and a year later, after the end of treatment, there has been a significant increase in IQ, and the IQ goes from an average of 90, which is 10 points lower than the average, to an average of 100, which is the normative range. So when we change the conditions, when we change the context, we can change children's IQ. IQ should not be considered a biological given, a genetic determinism factor, but a reflection of how the child is responding to environmental threats and sources of protection. When we look at the socio-emotional behavior of young children, preschoolers exposed to violence have more relationship problems and more oppositional behavior, separation anxiety, internalizing and externalizing problems. Early physical abuse is more predictive of behavior problems 9 years later than physical abuse after age 5. So the first 5 years really stamp us with a sense of who are we and who will we become? Are we lovable? Are we capable of love? If we are encountering adversity later on, after our sense of trust has already been relatively well established, we are better able to cope with it. And another recent finding from Angela Narayan, the same postdoc that found the IQ change, is that children who witness domestic violence in the first 3 years of life are more likely to engage in perpetrating domestic violence as teenagers than children who witness domestic violence at 9 years of age, but not at 3 years of age. So we have to start really thinking very seriously about the long-term consequence of early conditions. And of course, the fact that post-traumatic stress in the first 5 years of life looks very similar to post-traumatic stress in school age, adolescence, and adulthood. We are now 0 to 3, the National Center for Infants, Toddlers, and Families is redoing under the direction of Charlie Zina, who is going to be here in February to give the second Patricia Van Horn Memorial Lecture, and I hope you do come to hear him because he is an extraordinary speaker, an extraordinary researcher and clinician. He is leading the diagnostic classification manual for the first 5 years of life. And once again, we're finding that the manifestations of post-traumatic stress in the first 5 years of life are very similar to the manifestations of post-traumatic stress later on. Now, I was going in the direction of what are the long-term consequences of early childhood abuse, and I just want to tell you very briefly, going back to the Kaiser Permanente study, that the ACEs, the adverse childhood experiences that were identified then, which are briefly manifested here, 10 more minutes, thank you very much, are associated with adult depression, and when you have 4 or more early childhood adversities, you have a 5-fold higher likelihood of getting depression than if you have none. So that's at the level of psychiatry. At the level of substance abuse, both for alcoholism and drug abuse, we have that same shape of the more adversity, the higher the risk. And again, because trauma lives in the body, the more likelihood that we will get adult ischemic heart disease in adulthood, as well as many, many other physical illnesses. And the same thing happened with another study, again, of more than 5,000 people, this time focusing specifically on psychiatric problems. Here again, we found that the more adversities, the more likelihood that we will have 6 or more diagnoses in the DSM-5. So, based on all these findings, the American Academy of Child and Adolescent Psychiatry has said that we should assess for trauma, we should screen for trauma, we should screen for child abuse, exposure to domestic violence, exposure to community violence, exposure to neglect, routinely, whenever we get a referral. And parents and caregivers should be included in the treatment of their children whenever possible, regardless of the child's age. And trauma-focused psychotherapy should be the first line of treatment whenever trauma has been identified. Now, there is a gap between the state-of-the-art recommendations always screen from trauma when you get a clinical referral and what actually happens in the field. And in one study by Cindy Crusto at Yale University, she went to a community mental health clinic, just like a regular community mental health clinic, and looked at children aged 3 to 6 years of age, primarily poor, because the populations that go to community mental health clinics tend to be poor, and primarily ethnic minorities, and found that in about 43% of the cases, the diagnosis was social, emotional, or behavioral problems. 23% needed parental support and education, 14% had developmental issues, and only 13%, hefty, a substantial amount, had exposure to violence and abuse. And then she said, do you give me permission, directors of the clinic, to ask the parents about a trauma screening? Is the trauma screening that we use in our program, the Child Trauma Research Program, is called the TESI, Traumatic Event Stress Inventory. And it's a list of ACEs essentially, but it is much larger because it also involves non-personal trauma. And lo and behold, she found that on average, the children experience almost 5 traumatic and stressful life events that had not been identified during the assessment and were not part of the treatment. And almost half had experienced okay, 5 or more life events, and 39% had symptoms of post-traumatic stress disorder that had been misdiagnosed as depression, anxiety, defiance, oppositional behavioral problem, etc. So the treatment that these children were receiving was mismatched to their actual experience. And that is really the reason that we developed child-parent psychotherapy as a form of treatment where we lead with the question of what happened to this child, and where safety in the relationship, safety in the environment, safety in the sense of self is the guiding criterion for how treatment is conducted. And I'm not going to go into great detail. It's written about, etc. Let me just say that it's developmentally informed on one hand and culturally informed on the other. Those are our 2 book endings. And in the middle, it's attachment, it's trauma, it's psychoanalysis, it's learning theory, is cognitive behavioral strategies, is a very eclectic, integrated kind of treatment. But what I do want to say is that the emphasis is on protection from trauma, protection from adversity, protection from misattunement between the parent and the child, and affect regulation both within the self and in the parent-child relationship, with the direction of hope towards improvement in the future. And the findings, we have now 5 randomized studies. I will only tell you about one that was specifically focused on children that were referred for domestic violence exposure, children and mothers referred for domestic violence exposure, but where we found, as we asked, that they also, like Cindy Crusto's children, had 5 or more types of trauma exposure: child abuse, sexual abuse, community violence, intrusive medical procedures, loss, tragic loss of a person very dear to them. And the empirical findings are that the children had reduced number of post-traumatic stress symptoms relative to the controls, even though the control children were having individual therapy or their mothers were having individual therapy, and reduced number of behavior problems, and the mothers were having reduced number of post-traumatic stress symptoms. And what this tells us is that when it comes to young children, focusing on the safety in the relationship, treating the relationship between the parent and the child in situations of trauma, child abuse, domestic violence, and so on, is more effective than treating the parent individually or treating the child individually. And the percentage of children diagnosed with PTSD at completion was significantly different. I want to tell you that this child who had child-parent psychotherapy, this is an N of 1. We had one child at the end of treatment that had continued to have symptoms of post-traumatic stress, and that child had a mother who had returned to the violent father, so that the domestic violence had started again. And interestingly enough, the mother's PTSD also declined at the end of treatment. Now we have to remember, again, because child abuse has to happen in context, as Bill Harris, one of the real champions of child abuse funding in the federal government, said that we are dealing here with a supraclinical problem. It is not just a mental health problem. It is a problem that can only be resolved by having a sociological approach as well as a psychological approach. And this in turn takes us to the efforts that are happening now in a few places in the United States. Connecticut is one place, San Francisco and the Bay Area is another place, to create trauma-informed systems. And the way we define trauma-informed system is that instead of asking, what is wrong with this person, we are asking, what happened to this person? So the theme is again, screening, 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 and being open to knowing. And the idea is also that when we look at systems from a trauma perspective, we can see vicarious trauma in child welfare workers, vicarious trauma in the police, vicarious trauma in mental health providers, vicarious trauma in doctors or physicians, pediatricians who are constantly bombarded by children who are having a very hard time developing well, failure to thrive, behavioral problems. And we're finding, for instance, that at San Francisco General Hospital, the medical problems and the psychological problems are very much associated. The Department of Public Health in San Francisco has engaged in a system-wide effort to help employees, from the janitor to the directors of programs, to think of the pervasiveness of community violence, child abuse, domestic violence as hidden factors in aggression, affect regulation, and in the problems that they find in themselves and in others. And we're now working across 7 counties to try to create systematic screenings in pediatric settings, in childcare settings, in child welfare settings, and in the judicial system, so that people can think about themselves. Did this happen to me? Did this happen to me? And how might it be affecting my lack of patience, my judgmental attitude, my feeling of being exhausted at the end of the day, And how can I engage in self-care as a way of becoming a more effective treatment provider, service provider, but also as a way of improving the quality of my life. And hopefully next year, when I come again, I can tell you what progress we've been making, but it would be wonderful to engage in a dialogue because Israel has so much resilience, so much knowledge, so much wisdom, and at the same time, so much burden that a dialogue between us and what you have learned and what we can teach each other and learn from each other would be most welcome. Thank you very much.